PGY2, who's giving the admin and policy lecture today. It's called Documentation, Cover Your Ass, and Improve Patient Care. I'm going to be going through 3 different cases from MedMal Reviewer, MedMal Insights. Come on. And expert
It's my favorite subject. Too.
Oh, can't wait. Expert witness. 3 different cases, and I want us to focus on the documentation aspect of it, not actually the medical management aspect, because obviously if they've been in MedMal Reviewer, there's a lot to say for the actual medical management as well. So I'm going to be making the argument that documentation is not just for appeasing the admin gods. It might actually also be a tool for us to improve our patient care. So my first tip is that the chart should read like a story. If someone else is looking back at your chart, they should kind of be able to follow your logic in which how your management changes over time. And if there's anything new or shocking about something that happened in the patient's course, they should be able to kind of see your response to it. So the first case is from MedMal Reviewer. It's a 47-year-old male. He comes in with 16 days of abdominal pain after a gastric bypass, or female, sorry, 47-year-old female. She came in with 16 days of abdominal pain after a gastric bypass surgery. She had wound dehiscence around the JP drain, purulent drainage, and pain. Her first visit showed a temp of 100.3 orally, a heart rate of 114. Her BP was pretty normal, sat 100%, but she was a little tachypnic. So the very first visit, she gets labs, really just CBC, BMP, showed a white count of 16, and she also got a CAT scan. The CAT scan was notable for subcapsular fluid, possibly bile leak versus blood per the radiologist's comment, abdominal wall inflammatory changes, no definite fluid collection around the JP drain, and a post-op ileus. Don't read the whole thing. The whole point is just so you see what's written in the assessment plan. This is the first physician that saw her on the first visit. He goes through in detail, talks about how he called the bariatric surgeon, discussed what the fluid might be on the CAT scan, and actually provided an alternate diagnosis for what the fluid actually is. So the surgeon had said that during the surgery, there was a lot of bleeding and it could be just old blood under in the liver. Too long didn't read. Again, detailed documentation discussion with bariatric surgeon. He even goes step by step and reports what he told the bariatric surgeon. He provided an explanation for the subcapsular fluid, decided on a plan with surgery and the patient. He actually had a close follow-up. They had a visit that they scheduled for her and reviewed very specific strict return precautions, which he documented. 2 hours later, she comes in by ambulance again for severe pain, abdominal pain. Triage vitals, afebrile, getting more tachycardic. No BP was listed in the triage, 100% on room air, and she's a little bit more tachypnic. And here we see the second visit, which was a different physician, his note. This is a part of the note. If you can't read that, it says CT scan earlier was fine. And the clinical impression, which just says post-op abdominal pain and wound infection. This is from when they had paper charts. Apparently this is called a T-chart. We have it now.
Yeah.
I've never used one or seen one.
Downtime.
Or downtime. I guess I just try to avoid seeing patients during downtime. Just kidding. So the first physician also used a T-chart, but he separately went and typed up another note to fully explain the course and what he was doing. I think probably he got a feeling that discharging her was, it was a borderline decision. He kind of didn't know if he wanted to keep her or not. So he kind of went through and did a little extra documentation. The second physician, this is kind of what they did. No repeat labs or imaging. He didn't address that at all, didn't explain it. Final diagnosis, just called it post-op pain. Discharged her with a heart rate of 142 and didn't mention that anywhere. The plan that he wrote was home with NPO status, but he may have small piece of toast. Here you go. Exclamation point. Patient outcome, obviously it's not a good one. She was found deceased 4 hours post-discharge by her husband. The autopsy showed 5 liters of purulent hemorrhagic fluid in the abdomen. So, first visit, to recap, discussed all abnormalities, detailed medical decision-making, considered several differentials and listed them, why they may or may not be, and what he decided was the most likely. Had a backup plan for her, included return precautions, which she followed and came back for worsening abdominal pain. Second visit, didn't address any abnormalities, no medical decision-making, no differentials included, no return precautions. Here from MedMal Reviewer, we have a documentation rubric. They like to go through and rank all the documentation by this rubric that they've made up. It's 20 points total. They include 2 points for a brief overview, just age, sex, chief complaint, relevant symptoms history, abnormal vitals, and 1 to 2 sentences about the story. Testing, rationale for ordering, address any abnormalities, why no further testing is needed. That's after 3 points. Then the therapy, rationale for treatment, and the actual response to therapy once you give the therapy. So a reassessment is included in that. Differential, minimum 3 emergency diagnoses that you have to consider. Diagnoses that are ruled in or out. Conclusion based on results and common complications. Then discrepancies, that's only negative points. So if there are discrepancies in the chart, you lose points. Aftercare, the treatment plan, follow-up, return precautions, and timeline. So for the first visit, he scored a 17 out of 20. Second visit scored a 2.5 out of 20. Both physicians were named in the suit, so that didn't change. But only the second EM physician was deposed. The EM physician group settled out of court. Next topic, discrepancies. Again, don't read the whole thing, but I do want you to notice just where it says triage complaint chest pain. This is the triage nurse note. And then under assessment, I believe it says denies chest pain. Yeah. Then the physician documentation. Specifically, I want you to read this sentence. He doesn't mention the words chest pain in his HPI, but he does say that the patient is complaining of abrupt onset of the sensation that he had a lid of a pain can that began in his epigastrium and slammed up into his jaw and then came down and continues to compress on his abdomen, which sounds like chest pain. The workup included CBC, CMP, CK, PT, PTT. He also got a CT of just the abdomen pelvis, non-contrast, because the patient had an anaphylactic reaction to dye. And then he was admitted after the CT abdomen pelvis didn't show any abnormalities for chest pain. That's what the primary diagnosis says. Disposition, he went to obs. Later that evening, patient died suddenly. He had a ruptured thoracic aortic aneurysm. He had a history of a valve replacement. I didn't let you guys get a chance to read the whole HPI, but so in court, the biggest question that they had that they really anchored on was, doctor, why didn't you order a chest x-ray on a patient with chest pain? Triage complains chest pain, his admitting diagnosis is chest pain. There was no chest x-ray, no CAT scan. It goes back and forth like this for many pages. This is my favorite part. Who entered the words chest pain there into primary diagnosis? The doctor said I did. Okay, why did you enter chest pain? Well, I think my primary concern at that point was making sure that there was an indication for the patient to get further telemetry. I bring this up because sometimes we skip over the radiology indications for our imaging. We just say chest pain or shortness of breath for a chest x-ray really quickly. It doesn't really help the radiologist when they're trying to rule in or out something. I know they're supposed to go through the entire chest x-ray, the entire CAT scan, but they have a lot of imaging to get through, and it really helps them to give them some relevant history, something that they can focus on. And also, there's a big discussion, we've gotten a lot of emails about it, but our admitting diagnoses, actually making sure that they're reflective of the patient's condition when they're going upstairs. Because we typically have a better idea of what it is, other than just trauma or fall or pain due to trauma. Really putting in there the fractures that they have, it is going to be helpful when you look back on the documentation. So the recap, we already went through this. Chest pain is written all over the chart, no mention of chest pain. In the deposition, the physician says that he did not remember the patient having chest pain and that the patient definitely denied having chest pain. That was never actually mentioned as HPI. Outcome, died of thoracic aortic aneurysm. So address discrepancies in your HPI. Don't rely on the nursing triage to try to address the discrepancy. You're ultimately the person who's going to be deciding what the treatment is, the response to treatment. You're the one admitting the patient. Consider why the chief complaint is listed as is. If the patient said that they had chest pain at triage and now they're denying chest pain, maybe ask just a couple more questions, because maybe they did have chest pain at one point and their answers are changing now. So just consider that even though they're denying it now, maybe at some point they did have it. Admission diagnoses matter, accurately fill out the radiology indications, and if you have a moment, I know this is not always possible with the volume that we have, if you have a moment, try to just briefly take a peek at your chart from an outsider's perspective, see if it makes sense when you're reading it. If the story makes sense, if your response to things makes sense, it helps you catch things that you might not otherwise catch, even about your own patient management. Timestamps and reassessment notes. So timestamp big events. For example, CTA read that was significant for a large PE. Make a note that you saw it and what you're doing, what your plan is to address it. It can be literally 2 sentences. Patient not tolerating BiPAP. Let's say you're expecting that the patient might need to get intubated. Just a sentence that you're trying BiPAP and that the patient does not seem to be tolerating it. It explains later on why there's suddenly an intubation procedure note. If the patient is refusing interventions, maybe take some time to put that into a note, because once an outsider is looking back on it and it's clearly indicated that this patient needs a unit of blood and they didn't get it throughout their stay, they're tachycardic, and you haven't written anywhere that that has been refused, it's very confusing. So it's an easily explainable thing. Document your decision to give TPA or to not give TPA. So that you discussed it with the family, and then the reasons for either offering it or not offering it. And then just timestamp when you order blood. Just really quickly make a note, blood ordered, because we know that things get lost, techniques get canceled. The lab doesn't always do things in a timely manner. The blood bank doesn't either. So as long as you show your intention and you follow it up, you can just put a little timestamp in the chart. Reassessment notes. These are especially easy to do for boring patients. I know it takes time, but a couple sentences, 1 sentence, patient is comfortable eating his turkey sandwich in bed. It can, if that patient does take a turn, become a not boring patient, at least you have a course there. Patients that are, you can do it on patients pending CT scans, just write that they're still pending their CT scan, they're stable, they're comfortable. Personally, I try to do it every 3 hours. And you can even have a little smart phrase. It's really easy. Patient is pending blank, vitals are unchanged, downtrending, improving, whatever appears comfortable, uncomfortable, bored, whatever you want to choose. Okay, so this is my last case that I'm going over. It's about consultants. Chief complaint for this one is a headache. So patient is an adult female presenting to the ED with sudden onset, 10 out of 10 headache, vomiting, vertigo, and photophobia. Labs and imaging, basic labs, CTA head and neck. CTA head and neck did not show any cervical artery dissection, no intracranial hemorrhage, and there was what was termed an incidental finding. It was a large pituitary adenoma with central necrosis, displacement of optic chiasm, invasion of the cavernous sinus, destruction of the sella, displacement of the third ventricle, and compression of both carotid arteries. Which doesn't sound good to be called an incidental finding, but you know, all those big scary words like destruction, displacement, compression. So an official neurosurgery consult was called, talked to him over the phone, read the CT findings, but he didn't document what he actually read to the neurosurgeon, and only documented that the patient is to call the neurosurgeon's office on Monday for an appointment in 2 to 3 weeks. So and no MRI needed at this time. So that was what was documented. Not a great outcome. 3 days later, patient is found unarousable, aphasic, hypotensive, febrile with right hemiplegia. The repeat CTA shows hemorrhage into a now enlarged adenoma and an occluded left carotid artery. So when talking to consultants, document who, when, and why. Instead of something, especially when they're refusing to come in like this neurosurgeon did, for instance, instead of writing something like called neurosurgeon on call, discuss CT findings, neurosurgery, refused in-person consult, stated patient can follow up in clinic for further management. Probably not a great way to phrase it. A suggestion that I found from the last month's MRAP mailbag recap, they said to phrase it a little bit more like this, which would be spoke with Dr. Blank, always use names, over the phone at 10:15 to review CT results and request in-person evaluation for new concerning symptoms of sudden onset headache, vertigo, and vomiting in the context of a large pituitary mass. So you would say that you requested the in-person consult. You don't need to say that they refused or they're not coming in. Just make sure you timestamp, and then you can start working on escalating. You don't escalate in the chart, you escalate with the neurosurgeon or with the department. The chart is not a place to have kind of petty arguments about who refused, who is or isn't coming in. Ultimately, what's best for the patient is to find a way to get an evaluation by somebody. And you're not going to do that just by documenting in the chart the person didn't come in. So a couple ways to do this that they suggested is when talking to the neurosurgeon, you can say something like, I really think this person needs an in-person evaluation. If you're not doing it, do you have any suggestions who I can call for a second opinion, or who is supposed to become, who can come in your place if you are not the person that is going to be doing it. If that doesn't work one-on-one, then you would have to go to the department head and go up the chain that way. But again, probably not best to do that on the chart. Just say that you requested an in-person evaluation and timestamp it. So my final thoughts, can covering your ass also actually lead to better doctoring? I think it can. Having the role of reassessing every 3 hours actually reminds me to reassess. Putting in timestamps actually reminds me to take a look at what I'm doing, when I'm doing it, and what my response to certain new lab values and radiology reads is. Maybe that's just me as a newer resident. I still kind of need those reminders. I think probably for those who've been doing this a lot longer, they don't actually need the documentation piece to remind them to do certain things. But personally, I found it helpful. The other piece of it is that I feel less hopeless about documentation when I try to find some kind of meaning in it for our patients. So if we're sitting there forever and just charting and not able to kind of do what we thought being a doctor was all about, instead of just getting annoyed at it, I've tried to think of it as a way to still be doctoring. So, yeah. Any questions, comments?
I think that's great. Very good job. I think two things is right. When you use a consultant, put down the name of the consultant, and never accept a trainee as that person, a fellow. Right? It's still not good enough. And I think your last point was spot on. It's not just about pleasing the administrative knuckleheads of the world. It's about the next person who comes, reads your chart, has a better understanding of that patient, and you are delivering better care. Those are two excellent points.
Yeah. I think it's also important to remember that just because you're documenting doesn't mean it's okay. Like that first case, they documented really well. They documented poor care, right? Like, let's say there wasn't that terrible doctor on the second visit. I think they still would have settled because in the end, they discharged the patient who never should have been discharged, right? And a consultant, and this is two cases, right? The consultant telling you to do something that you think is not right, don't do it. Don't accept that. Documenting that you think this is not right and all the reasoning and everything, in the end, you're still making the decision to send that patient home. And I think that's, documentation is really important. I like to use documentation to make sure my thought process on the patient is right, and less about making sure I'm documenting everything that somebody else wants to see in court later on. I think it's really important to document for yourself. It keeps my thought process in mind. Sometimes I'll go and I'll write the note and I'll be like, oh, I didn't think about this when I was actually talking to the patient. I can go back, ask the patient a question. I can help my workup even a little better. But also for the next doctor who's going to be like, okay, this is what they did, this is what they thought, and that's really important. Less about what's going to happen in court. I never think about what's going to happen in court. I never ever try to practice about what somebody else who's not going to care for my patient thinks about my documentation. I do it for my patient and for whoever else is caring for that patient.
Yeah, I think those are really good points. I was also thinking documenting to make it read like a story, not just for court, but for the providers that are coming after you.
I agree with
that. You would
Totally.
admit to the inpatient.
There's nothing I hate more than documentation for the sake of documentation. Somebody writes a note just so they can fill in all the boxes that they wrote the note, right? And it doesn't make any sense. Like we see this all the time. Things are cut and pasted, and then the automatic thing. Like, writing a paragraph about the patient, about your thought process is probably the best thing you can do for yourself and for your patient.
That's why soap notes were better
Oh,
than electronic notes. I was in the time where all notes are written, and you really had to think about what you were writing because you just couldn't click boxes. It's this crazy thing about review of systems determines the billing of a chart. It's the opposite. You know, that is the opposite of what we do, of what we should do.
Nick, I like the frequent reevaluation notes, like if you try to do it every 3 hours, especially at our institutions right now, medicine has built into their workflow like 4 handoffs before the patient gets to the primary team. And
Oh, yeah.
they're really not working on it too well. So I think if you can do the frequent reevaluation notes, you're really doing your patients a service right now. And it's probably better for their safety, for chart review, and for the person that finally gets them at the next day, what actually happened.
I don't know for the people at home if you guys can hear it, but Dr. Lucchese was saying definitely include the name of the person that you're talking to with the consultants and don't take a name of a fellow or a trainee. Dr. Schechter was saying that documentation is mainly for him to go back and reassess his thought process and if he's missing anything on a patient. And also just because you're documenting it doesn't mean it's the right medical management, as we saw in the first case. They clearly sent home a patient that probably shouldn't have been sent home, and probably would have been sued regardless of whether she had that second hospital visit too. And then Dukas was saying that the frequently reassessing patients is super helpful, especially for the inpatient team, because there's 4 handoffs that happen in between us admitting a patient and the patient actually getting to the team that's going to be taking care of them.
Good job, Nick.
Great job.
Thanks, guys.